a great friend of Mates in Construction and a great scholar is Professor Annette Beautrais from Christchurch. Christchurch has its own challenges around construction since the earthquake wiped out such a beautiful city. And Annette has written quite extensively about suicide and suicide prevention and about how do we take the research findings, and there's lots of research, how do we actually make that practical on the ground? What's a strategy that will work? And so we were delighted when Annette said that she would come and be part of the conference. And she said, but I don't want to come as a speaker. I said, that's all right, we'll give you another role. Plenty of roles, you don't have to be a speaker. And what we've asked Annette to do is to be a connector, to actually listen to the speakers and then connect it back to the theme, which is, mental health in the workplace. Do we care? And that's our focus. And I love the fact that Kevin Hines said, well, it shouldn't actually be mental health and physical health, We're integrated beings, we're one whole person. How are we looking after all of us? So I'd ask if you'd welcome Annette up.
Thank you very much for the introduction. I'd like to congratulate the organisers for creating and constructing this conference. I am absolutely delighted to be here. I think that this conference addresses an issue whose time has come, and that is mental health, sorry Kevin, health and well-being in the workplace. And I started in this field 25 years ago doing suicide prevention. And at that time, and for a long time thereafter, youth suicide dominated politics, it dominated the development of suicide prevention policy, and it dominated suicide prevention programs. And I have a background in statistics, and when I went into the field, I said, but look, youth suicide accounts for, in most developed countries, Australia and New Zealand, at that time, about 20% of all suicides. The vast majority of suicides that happen in developed countries, more than 60%, that they occur in men of working age, men aged 25 through to 65. If we want to make a difference to the total suicide rate, we have to focus on the group which contributes to the majority of suicide deaths. And they said, that's not what the politicians want to hear. The World Health Organization asks us every year what we're doing about youth suicide, so that's what we're focused on. So when I say this is an issue whose time has come, I've waited 25 years for this, and I've learned along the way that there are some things that you can try your hardest to facilitate, but you actually have to wait for the people to catch up with you. And I think that Mates in Construction has actually done a huge amount of work in Australia, and it's filtered through to New Zealand, in preparing the population and the workplace for what we are now focused on, which is mental health and suicide prevention in the workplace. And I also want, talking about Christchurch and the rebuild in Christchurch, and the importance of mental health in the workplace was brought home to me because my house was being repaired, and all of the houses that are being repaired have these huge orange hazard boards posted out the front, and I'm not supposed to go on the property, and so on and so forth. And the hazard boards say things like, no floor, they remove the floor, and electrical wires, and concrete hazard because they've broken it up and are taking it away, and dumping everything in a skip. And there's all of these physical hazards listed. There is nothing, and I've looked all over town, no one mentions anything about mental health. But I walked onto my property, and there were a whole lot of subbies and tradies, and it was a huge amount of work, and they're all there. And I walked on, and this guy dropped, he was a painter, and he saw me, and I think he saw a woman, and he wanted to talk to someone, and he stopped what he was doing and rushed up and talked to me. And in 3 minutes, I learned that he was from South America. He was actually trained as a chef, but he was working as a painter, and he hoped he was doing a good job. He had broken up with his New Zealand girlfriend of 3 years, so all of his time in New Zealand had been with her family, and now he'd lost all of that. As a consequence, he wanted to go home and see his parents in South America, but he had visa issues. And he also wanted, if he was going that far, he wanted to go for 6 weeks. He wasn't certain that his employer was going to give him the time off or that he was going to be allowed back in the country. And on top of that, this is all in the first 3 minutes, on top of that, his landlord had just said, you have 3 weeks to get out because house prices houses are so scarce, house prices are so high, I'm going to capitalize on this and I'm going to sell the house. And, I thought, what do I do? This guy really needs help. And I rang around a whole lot of places, and basically there was no one to whom I could refer him. But to me, that just illustrated very clearly what the gaps are in our workplaces in terms of mental health. We focus on safety, but it's on physical safety. But we seem to have forgotten the contribution that mental health and that well-being make to physical safety. You think about the crane driver on the construction sites in Christchurch is dominated by cranes, and how important it is that that guy and all of the people whose work is associated with the cranes, for example, is actually functioning very, very well. So I also want to talk about the two themes that I think emerged from our two Kevins today, and I can't tell you how amazing it is to have these two people, one who jumped from the Golden Gate Bridge, one whose job has been to take them back over the rail, speak together. Kevin Hines spoke his extraordinary story, and he spoke very eloquently of his history and his story. And that illustrates another theme whose time has come in suicide prevention. And that is the issue of lived experience. And it's Kevin and his story who've paved the way for people with lived experience of mental disorder and suicidal behaviour to be included in suicide prevention conferences. That wasn't the case 25 years ago. It wasn't the case 5 years ago. This year, you would not have an international conference on suicide prevention without including someone to talk about their experience. So thank you, Kevin, because he's really paved the way for that. And I think it's a shame, and it reflects on the stigmatization of suicidal behaviours and of mental health problems, that the last people who've been invited to the table of suicide prevention are the very people who have made suicide attempts. We have a great deal to learn from them. And I also think it's incredibly important that people like Kevin provide a visible champion for suicide prevention, for people to understand the people that this problem affects. And it illustrates very clearly to people that if you can interrupt the train of suicidal ideation, the rumination about suicide, if you can act to get people to help, if you can abort suicide attempts, then in the vast majority of cases, the person will get through the crisis and they will not go on to die by suicide in another attempt. And this is a myth, and it's particularly important, and the experience with the Golden Gate Bridge, which after 2,500 deaths over decades still does not have barriers, though they tell us, going to put them up. But if you actually look at the history, and there's a wonderful paper, it's about 60 pages long, but it tells you the 60-page history of efforts to get barriers on the Golden Gate Bridge. It is littered with stories of people in governance roles, in funding roles, in civic responsibility roles, who believed the myth that if someone doesn't die, if someone's intent on dying by suicide, they'll find another way. So what's the point of spending money, a huge amount of money, putting barriers on the bridge because they're going to do it anyway? Now that's a myth, But it's amazing how much it has dominated the arguments about putting barriers on the Golden Gate Bridge. And I think that Kevin's story destroys that myth, and it's very important that it breaks down the barriers and sends a very clear message that we need to be able to talk openly and widely about suicide in a meaningful way and give people good and clear and accurate information about suicidal behaviours. And then I want to talk about the other Kevin and Kevin Briggs' contribution, and the theme that emerges from that is, and again, it's another theme which currently is which presently is very current internationally, and that is on promoting training around suicide prevention and mental health in the workplace. And I think Kevin's story tells us about the need for training in mental health issues and suicide prevention for people who work in the health and social services and in emergency services. And it's amazing that there is no mandated training for people in these services. And it's amazing that the efforts that are currently underway to try and mandate training are met with a pushback from political figures and from professional bodies who say, we're not going to be told what to put in our curricula. And I think I've spent most of the last year running 8-hour training sessions on suicide risk assessment to nurses in the acute mental health wards of hospitals. And I'm only called in reaction if there's been a suicide in the inpatient unit and there's been a complaint about services to the Health and Disability Commissioner. There's an investigation, the media's got hold of it, it's on the front page, and I'm called in and I have 30 nurses, very defensive nurses. And at the end of the day, they all come up to me and they say, best training we've ever had. We've never had training in suicide prevention. I've been a nurse for 20 years on the acute inpatient ward, never had training like that. I mean, I think that's absolutely amazing. We're failing the people who are delivering services, and we're failing the patients who are receiving services if we don't mandate training. And it's not just for professionals, it's people in the police. I mean, we have witnessed in the last 50 years the biggest change in mental health services we're ever going to see. And that is the closing down of mental health hospitals. And what we did was we opened the back doors and we pushed these people out into the community without doing pilot studies to see where they were going to go and how they were best going to be looked after. And at the same time as we opened the back door and pushed them in the community, we closed the front doors and we reduced the number of acute inpatient psychiatric beds. So these people are out in the community, and the police will now tell you that they are the largest social service agency in the country, and many of the people that they deal with are mental health patients. But the police don't have good training in suicide prevention. I'm just giving the police as an example of emergency services. Now, my understanding is that if there's a mental health patient call out, the police send 2 people, and they allow 4 hours. So that's an 8-hour shift gone with 1 call out. But they don't get good training. And I think Kevin Briggs has highlighted the fact that he's sought out training, he's got very good training, but it's not standard practice for people in those professions. Kevin also talked about the importance of self-care. And we have to remember that the people who are working in these fields with people who have mental health problems and people in workplaces have problems themselves, and self-care is incredibly important. So just to summarize, I think the 3 themes that have emerged are that we are all all of us, moving the field forward immensely in terms of addressing health in the workplace. The second theme is lived experience. It is so important to have visible champions for mental health, mental disorder, and suicide prevention, and to learn from their stories. And the third theme is the need for suicide prevention training in health and social services, emergency services, and in the workplace, and we're going to hear much more about this as we go through the day. The challenges are how we can mandate training in suicide prevention for the people who most often have to deal with suicidal people, and how we can expand training within workplaces so that people are well informed about mental disorder and suicide prevention and are able to help the people with whom they work. Thank you.